are particularly dangerous to pediatric patients. And then the ugly stuff that's come up since the pandemic, both an increase in overdoses and then problems with ineffective and potentially dangerous COVID treatments. So we'll start off talking about the general approach to the poisoned patient. So obviously with poisonings, we have some unique concerns about securing the scene. The history becomes critical. There are specific things we look for in the physical exam. And then in terms of treatment, we've got decontamination. For some poisonings, we have antidotes, but then the mainstay of treatment is supportive care. So with respect to securing the scene, we particularly want to think about the things that are dangerous to us. So, in our area, probably one of the most dangerous things that we could potentially encounter are organophosphates, typically used in agriculture. These tend to be really persistent, really difficult to decontaminate, but critical to decontaminate before you're putting someone in the ambulance and taking them to the emergency department. Obviously, we deal with meth labs and the risks that go with that. And then probably the most common thing that we deal with is IV drug abuse. And although it's less the toxin that's dangerous to you, these are patients that have needles and potential bloodborne pathogens on them. With respect to the history, the key components are getting the time of the ingestion, and then the pill bottles are very helpful. It really does make a difference whether we are, if we're dealing with, for example, an extended release formulation of a certain drug versus the immediate release. So not just the pill counts, but the exact formulation of the medicine is really helpful. And so bringing the pill bottles in can be particularly helpful. In terms of the physical exam, the focus is on looking for toxidromes. So for anticholinergic toxidromes, like we would see with organophosphate poisoning, these are the people who are hot as a hare, mad as a hatter, red as a beet. So increased heart rate, increased blood pressure, respirations tend to stay the same. The temperature tends to be up, pupils are dilated. If you are listening for bowel sounds, they tend to be gone. And then these patients tend to be quite dry. Excuse me, I'm going to correct something I said. So cholinergic are what you see with organophosphates. Anticholinergic are what you see with medications like Benadryl. You can also see with TCA poisonings this hot and dry. So I apologize for that mistake. So cholinergic, you tend to see pinpoint pupils, hyperactive bowel sounds, and then these people tend to be really diaphoretic. The opioid toxidrome is something that we see frequently. So heart rate and blood pressure tend to go down. The key finding is that the respirations go far down. The temperature can be low. Pupils are pinpoint. And they can be dry, although as you wake them up and they get that sympathetic surge, they can start to get diaphoretic. Sympathomimetics, like we see with methamphetamine, tend to be tachycardic, increased respirations, hot, dilated pupils, and sweaty. And then sedative hypnotic drugs like benzodiazepines tend to have decreased heart and blood pressure, notably decreased respirations. They tend to be cooler just because they have decreased metabolic activity, but they tend to be relatively dry. With respect to decontamination, like we talked about with organophosphates, there's some substances where you just need to decontaminate the patient before you can even contemplate treatment. But then the more common things that we deal with, things that are ingested, we do have the option of GI decontamination. So this is used much more rarely than it used to be in toxicology. And because there are risks to GI decontamination, we typically only use it for life-threatening substances that don't have an antidote. So for example, Tylenol is life-threatening, but there's a very effective antidote. And so it's rare that we'll use GI decontamination. Because this is complex to think through, that's why the protocol mandates either medical control or poison control contact before you would give activated charcoal. And activated charcoal is the one option we have for pre-hospital GI decontamination. In the hospital, occasionally we will use whole bowel irrigation, which is essentially giving a colonoscopy prep. Many times we'll need to intubate these patients, put in an NG tube and do that. It's very, very rare. I've done that for a toddler with an iron poisoning, but it's very rare that we do that. And then gastric lavage is even more rare, and that would be for something life-threatening without an antidote, and typically it's something that we're seeing within the first hour after ingestion, and that essentially mandates intubation. So these are very rarely used. The mainstay is first keeping the ambulance clear, keeping the ED clear of anything that's potentially hazardous, and then supportive care and antidotes. So with respect to antidotes, you could think of midazolam as an antidote for the sympathomimetic toxidrome. It doesn't completely reverse the poisoning, but it deals with the key effects of the poisoning. It decreases the heart rate, decreases the respiratory rate, protects patients against seizure. For opioids, we have naloxone. For the cholinergic toxidrome, like you see with carbamates, organophosphates, we have atropine, and these patients typically require large amounts of atropine. And then 2-PAM is an option that's carried by hazmat units. For cardiotoxic drugs, we can't reverse these completely, but we can mitigate some of the effects of beta blocker and calcium channel blocker overdose with calcium gluconate. For the anticholinergic toxidrome, there is no pre-hospital antidote. In the ED, we can give physostigmine. That's not something that fixes the patient and makes it all better, but it temporarily reverses the effect. It helps us make a diagnosis, and it helps us manage the poisoning. For sodium channel blockade, like you can see with Benadryl or tricyclic antidepressants, sodium bicarbonate will help overwhelm the sodium channel blockade by giving sodium. And then for cyanide, we have sodium thiosulfate. You can think of supportive care with the ABCD mnemonic. So with airway, there certainly are some poison patients that we need to control the airway. One thing to think about is that in patients that tend to get really acidotic, we really depend on them to manage their own respiratory drive, to manage that acidosis. And so intubation is relatively contraindicated in aspirin overdose, similarly to intubation being contraindicated in DKA, because we want the patient to manage their own acidosis. But in other poisonings where you can't reverse the respiratory depression with Narcan, they're not protecting the airway, intubation is definitely indicated. Treating nausea can help to protect the airway. With respect to breathing, remember, we're dealing with both getting oxygen in and getting CO2 out. So supplying oxygen, and these are patients where end-tidal CO2 monitoring can be helpful because they've essentially sedated themselves. With circulation, fluid bolus is typically the first step, and then cardiac monitoring, because many of these drugs have cardiotoxic effects. And then disability, just considering the risk of seizure, both being ready to treat seizure and being ready to secure the patient if they do have a seizure. So one of the best things that's happened in toxicology over the last 3 to 5 years has been there's been a real improvement in the ways that we can treat opioid addiction. And so we have had improvements in success getting people off abusing opioids, but there's some important pre-hospital considerations that we have to think about. So the mainstay for treating opioid use disorder is medication-assisted therapy. So for some time, we've had naltrexone as a depot, long-acting intramuscular injection. So people who get naltrexone depot or Vivitrol is the brand name, they essentially always have Narcan in their bodies. And so they can't overdose, or it's very difficult for them to overdose, but it doesn't do anything for craving. And so it's been, there's some patients that it works well for, but in general, it's been less successful. And then for a long time, we have had methadone, which is an opioid agonist. It's long acting. It is effective, but it is more prone to abuse. And because it is dangerous in overdose, it's dispensed via daily clinic visits, which obviously can be a barrier to getting people into treatment. And so what's new is the combination of buprenorphine and naloxone. The brand name is Suboxone. You also hear docs refer to this as just bup. So this is buprenorphine, which is a partial opioid agonist, plus naloxone, which is an opioid antagonist. And so it's relatively safe in overdose. And of all these different treatments, it has the most evidence to support it. It is more effective than any other treatment in getting people off of abusing opioids. So it's dispensed in these films. The most common dosage has 8 milligrams of buprenorphine, 2 milligrams of naloxone, and then there are films that get put on the tongue. So you will come across patients that are on buprenorphine. If they're having withdrawal, for example, they couldn't get their buprenorphine for some reason, absolutely treat their symptoms. Typically, nausea is going to be the most predominant symptom. But if someone has had success getting off opioids, you don't want to treat them with opioids. You can in the pre-hospital setting, you can manage their withdrawal symptom. And then in any emergency department, we can give buprenorphine and start to get these patients back on their treatment. If this patient has acute pain, they just fractured an extremity, they can receive fentanyl, but you will typically need higher doses, both because they have some naloxone in their system, and then the buprenorphine has a very high affinity for the opioid receptor. So one of the big advantages of buprenorphine is that it is relatively safe in overdose. So because the buprenorphine is a partial agonist, it has less respiratory depression in overdose than any of the other opioids. So typically, unless it's mixed with other agents, it is rarely fatal. And so because of that, it's less likely to require naloxone. It looks a little bit different in overdose than other opioids because you don't get that same respiratory depression. So you can get pinpoint pupils, and you can get some respiratory depression, but it just doesn't look like someone who took a bunch of fentanyl or heroin. But if you do get someone who has gotten enough to overdose, or they've gotten it in combination with other opioids, you may need much higher doses of naloxone. Okay, so now we're going to move on to the bad. This is something that's always been with us, but I think this is worth emphasizing, because these are medications that, particularly for pediatric patients, one pill, one adult dose can be lethal. Not all of them are pills, some of them come as liquids, but these are medications that we want you to know about, because finding these on scene or finding these as a potential ingestant can completely alter the course of the call. So you can group these medications into 3 categories. There are those that have cardiac toxicity, metabolic toxicity, and then respiratory toxicity. So we'll talk about the cardiac meds first. So the medicines that have cardiac effects, where one pill could kill a pediatric patient, the top of the list is beta blockers. And of those, probably the most dangerous is propranolol because it has beta 1 and beta 2 effects. It's very lipophilic, so it crosses the blood-brain barrier. So that's probably the single most dangerous beta blocker in overdose. Obviously, you get decreased heart rate, decreased blood pressure. And one thing that can help you distinguish beta blocker overdose from a calcium channel blocker overdose is that beta blocker overdoses typically make patients hypoglycemic. And so you want to keep an eye out for hypoglycemia, and they may need to be checked frequently because they can continue to drop. Whereas calcium channel blocker overdoses cause hyperglycemia. So calcium channel blockers, also very dangerous in overdose. Obviously, verapamil and diltiazem. We've used amlodipine as probably the most common blood pressure medication that's a calcium channel blocker. And so when I'm trying to get history of in a pediatric poisoning, I generally ask, are there any heart medicines in the house? Is anyone on heart medicines? And that casts a pretty broad net and will help you help clue into that some of these medications might be in the mix. So the alpha-2 blockers are also dangerous in overdose in small doses. So there's clonidine, which is primarily used for blood pressure. Guanfacine is rarely used for blood pressure. We more commonly see it for pediatric ADHD. And then tizanidine is a centrally acting muscle relaxant. Of these, clonidine definitely the most dangerous. So with these, you also see a decrease in heart rate, decrease in blood pressure. They tend to independently decrease the level of consciousness. And then you also see decreased pupil size. So these can look like an opioid overdose, and they can respond partially to naloxone. They don't tend to wake up the same way that a heroin overdose would wake up completely with naloxone, but you can get some reversal. And so if it looks like an opioid toxidrome, even if you suspect clonidine, it's reasonable to treat with naloxone. Tricyclic antidepressants, obviously used much less frequently now than they used to be, but still are used in some cases for chronic pain and in some cases for sleep. Amitriptyline, nortriptyline are the most common. They tend to have the triptyline ending that indicates that it's a tricyclic antidepressant. And so these are medications that are really messy. They hit a lot of receptors. So you see increase in the heart rate, an increase in the QRS duration because there's sodium channel blockade. The blood pressure tends to drop. They independently decrease level of consciousness. And then they have this anticholinergic toxidrome and seizures. And so this can be treated with sodium bicarbonate for the QRS widening, midazolam for the seizures. But the key thing is getting that in the history because they can really help us to know what to expect. And then these are patients that in the hospital will often end up on a sodium bicarbonate drip that also helps them eliminate the tricyclic. The anti-malarial drugs are dangerous in overdose, hydroxychloroquine and chloroquine. So these are also used for rheumatoid arthritis and some other autoimmune diseases. They are less commonly now, but obviously these were touted as potential cures for COVID. They were studied for COVID and found to not be helpful. And they have a very narrow therapeutic range. And so these are, 8 pills can be lethal for an adult and 1 pill can be lethal for a child. So their primary effect is on cardiac rhythms. And so you will see decreased blood pressure, decreased level of consciousness, wide QRS. You can see ventricular arrhythmias and seizures. So unlike the tricyclics, you don't get that anticholinergic toxidrome, but otherwise they look similar as an antiarrhythmic. And then finally, the class 1 antiarrhythmics. These are less common, but there are some patients with chronic AFib that are on flecainide. That's dangerous in overdose. And then one medicine that's prescribed as a cough suppressant, benzonatate or Tessalon, if for pediatrics that can be potentially lethal. And so the primary effect here is increasing the QRS duration. Local anesthetics can also cause methemoglobinemia. And so this would be the kid who gets into the prescription cough medicine. With respect to metabolic effects, the list is a little bit shorter. So the top of the list are the sulfonylureas. So the diabetes drugs they generally start with a G and end with an IDE. So glipizide, glyburide, glimepiride. And so their effect is on decreasing the glucose. The thing that makes them tricky is that they can have a delayed effect. And so if we know that an asymptomatic child got into a sulfonylurea, they'll be admitted for 24 hours because they can have delayed onset hypoglycemia. So these are presentations where it's really critical to get that history and completely alters the course of the call. Toxic alcohols can be lethal to children in small doses. So isopropanol, rubbing alcohol, methanol, wood alcohol, and then ethylene glycol, which is an antifreeze. The early presentation looks like ethanol intoxication. In the late presentation, patients tend to have vision changes. They have an increased respiratory rate because of an acidosis, and they can be comatose. And so the problem is less the ingestants themselves and more that they get metabolized to a toxic metabolite that causes problems. We have other treatments for them now, but in the absence of any other treatment, the treatment for these is to have the patient drink ethanol. We typically don't do that for kids. And then the last one is salicylates. The one to watch out for is oil of wintergreen, which is available over the counter. One pill of aspirin is rarely lethal to a kid. You need about 3 grams of aspirin to get to a toxic dose, but oil of wintergreen has fairly concentrated salicylates, and that a couple of drops of that can get a kid into salicylate toxicity. And so these patients also get acidotic. They have an increased respiratory rate, an increased heart rate, decreased loss of consciousness. If they're able to speak to you, they often will complain of a ringing in the ears. And then with respect to respiratory effects, it's opioids. And so we're all familiar with the opioid toxidrome. I just want to point out a couple of ones that are particularly dangerous. So fentanyl patches have massive amounts of opioids in a really small concentrated form. So this is a picture of a 75 micrograms per hour fentanyl patch. These patches are meant to be worn for 72 hours. So in a 75 microgram per hour patch, you have 5,400 micrograms of fentanyl. The max dosing of the patch is 100 micrograms per hour. So for a 72-hour patch, you have 7,200 micrograms of fentanyl. So these are patients that can require large doses of Narcan, and if someone gets even an adult ingests one of these, they will be admitted and monitored, and often on a Narcan drip. OxyContin, the delayed release formulation of oxycodone, is also quite dangerous in overdose, right? And it can have more of a slow presentation because it's a little bit slower in onset, but it's a lot of medication dispensed over a period of time. Before we move on, any questions about the one pill can kill list? Okay. So I'm going to make a quick side note. This is not a one pill can kill medication, but these are medications that are surprisingly dangerous. Iron is very dangerous in overdose, and toddlers are particularly susceptible to this because a lot of the packaging can look like candy, and And so, although it's hard to overdose on children's iron pills, if a kid eats a whole bottle of these and and they're made to taste good, that can get them into difficulty. But when we really tend to see trouble are if they get into gummies that have iron in them. So this is organic, non-GMO, and can absolutely kill a toddler. So they taste good, they look like candy, but they have a significant amount of iron. I mentioned earlier that I'd done whole bowel irrigation for a toddler. I think it was 3 years ago that I took care of this kid. It was an 18-month-old that unfortunately died from an overdose, got into his mother's prenatal vitamins. And so these are, often if there's a toddler in the house, mom may have prenatal vitamins, and so this is just something that looks pretty innocuous, but is very dangerous in overdose. So we'll talk about the ugly aspects of toxicology in the pandemic. So although in total our overall call volume has gone down, we have seen an increase both statewide and nationwide in overdoses during the pandemic, both opioids and other medications. With all of the disruptions of the pandemic and the problems with mental health, we've seen a slow increase in the number of overdoses. It seems, so we reached a peak in July of 2021. Things seem to be improving slightly, but unfortunately, this has been a feature of the pandemic. And then I just briefly want to touch on ivermectin. We talked about hydroxychloroquine, which is very dangerous in even small doses. Ivermectin was studied for COVID-19. Unfortunately, in multiple randomized trials, it has not been found to have any benefit. Unlike hydroxychloroquine, it is not dangerous in in 1 or 2 pills of the human dose. The problem that we get into with ivermectin is that it is an antiparasitic that, besides being used in humans for parasites, is also used in veterinary practice. And so some people are getting the veterinary formulations. So although the human dose is about 3 milligrams, you can buy this horse dose online. 1 syringe will treat a horse that weighs up to 1,250 pounds. It's safe for pregnant mares, breeding stallions, any age of foal, but not safe for humans. Ivermectin in overdose, so it's a nerve poison. It looks a little bit like a benzodiazepine overdose or alcohol intoxication. It can be ataxic, and you tend to see an increase in heart rate, decrease in blood pressure. So again, not effective against COVID in human doses, not dangerous in human doses, and certainly is prescribed in human doses for parasites, but dangerous in the veterinary doses. So take-home points on toxicology with respect to the general approach. Remember, GI decontamination is rarely needed. Contact medical control or poison control if you think that's indicated. Supportive care is the key for the vast majority of toxicology. Know about Suboxone. It's an opioid partial agonist and antagonist. It's a very effective treatment for opioid use disorder, but presents differently in overdose than other opioids. As a side note, both emergency departments have programs now where we will start patients on Suboxone and then refer them to treatment because it is such an effective treatment for opioid use disorder. And then finally, there are a small number of toxins that are deadly to children in small amounts. Any questions on toxicology before I move on to anaphylaxis? So we'll do a brief review on anaphylaxis. So the diagnostic criteria for anaphylaxis, there are 3 ways you can meet them. And so it's a way of balancing how likely it is that an allergen caused the presentation versus what you're seeing in the patient. So way number one to diagnose anaphylaxis is that you have sudden onset of an illness, minutes to several hours, with involvement of the skin, mucosal tissue, or both. So either you have generalized hives, itching or flushing, swollen lips, plus either respiratory symptoms and signs like shortness of breath, wheezing, stridor, or a sudden drop in blood pressure. So you see those things where you have skin signs plus either respiratory signs or cardiovascular signs. It is likely anaphylaxis. Way number two is where you have a likely allergen or other trigger. And for this, you need two of the symptoms. So you can have either skin or respiratory, decreased blood pressure, or sudden onset GI symptoms. And the GI symptoms are the ones where, that's not what we typically think of with anaphylaxis, but patients that are exposed to something that's a likely trigger have one of these other signs plus a GI presentation with nausea and vomiting. You have to consider anaphylaxis. And then the final way is if you've got reduced blood pressure, shock, after a known allergen to that patient. So obviously, if someone has another reason to be hypotensive, you're not going to diagnose anaphylaxis. But if you have, say someone has a known allergy to bees, gets stung by a bee, and their only presenting symptom is hypotension, then you still have to presume anaphylaxis. And so for adults, systolic BP of less than 90 or a greater than 30% decrease from the baseline. And then infants and children, an age-specific low systolic blood pressure or greater than 30% decrease in the systolic blood pressure. So 3 ways you can make the diagnosis of anaphylaxis. In terms of treatment, this from the protocol. So if it is not anaphylaxis, if you're having a mild reaction, you can treat with Benadryl only. If there are signs of anaphylaxis, you treat with epinephrine. So unless you have an IV in place, you can use IM epinephrine. If you do have an IV in place, then you can do an epinephrine infusion titrated to clinical response. Fluid challenge. You can use adjuncts, Benadryl, albuterol, Solu-Medrol, but none of these replace epinephrine. Epinephrine is the only medication that fixes the problem with anaphylaxis. With pediatric treatment, similarly for a mild reaction, not anaphylaxis, you can use Benadryl 1 milligram per kilogram, IV, IM, or PO. For anaphylaxis, then you're using IM, epinephrine if you do not have an IV. So 1 to 1,000 epi, 0.01 milligrams per kilogram IM, up to a max of 0.3 milligrams, or a pediatric auto-injector. And then you can use the epinephrine infusion, 0.1 micrograms per kilogram per minute, IV or IO, titrated to clinical response. And then you have the adjuncts as well, but again, only epinephrine will fix anaphylaxis. So you may see biphasic reactions in patients that have been discharged from the emergency department. It can occur up to 3 days after the initial exposure, fairly rare, less than 1% of the time. But the risk factors that someone may be having a biphasic reaction are that multiple doses of epinephrine were needed to treat the initial reaction, or that they had a very severe reaction initially. Think about the differential. Obviously, ACE inhibitor angioedema can present similarly to anaphylaxis and is much less likely to respond to epinephrine and will more likely need intubation. Hereditary angioedema similarly may require intubation. Some patients have specific medications that either they have or that are cached at the local hospital that can treat that. Infections sometimes can present like anaphylaxis. I've also reviewed a case of a patient who had a pneumo, had subcutaneous emphysema, and so had significant facial swelling. that initially looked like anaphylaxis. So get a careful history, keep an open mind, but err on the side of treating anaphylaxis if any questions. So the key points on anaphylaxis: epinephrine is the first-line treatment. All of the other medications are adjuncts. Only epinephrine will treat anaphylaxis. And with that, are there any questions? Okay. So I welcome your feedback. You can scan this QR code here, use the link here. I'll also paste this into the chat. We want to give the best PCEP we can, and we really value your feedback. I have no other questions. Thank you very much.
Thank you, Dr. Macht.